Hi, Dr. Brian Kaufman, a retired family doctor and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. And I'm going to be speaking about some of the important papers from ASH, the American Society of Hematology's annual meeting 2023. This paper is about sudden death and cardiac arrhythmias, irregular heartbeats, associated with acalabrutinib in the treatment of chronic lymphocytic leukemia. And the bottom line is that acalabrutinib carries a low risk of sudden death in ventricular arrhythmias in chronic lymphocytic leukemia, small lymphocytic lymphoma patients. This information was presented by Dr. Jeff Sharman as the principal investigator on the abstract that was titled Analysis of Ventricular Arrhythmias and Sudden Death with Acalabrutinib from 5 Prospective Trials. It was presented at the American Society of Hematology's annual meeting held in San Diego, California in December of 2023. In the way of background, we know now that the introduction of ibrutinib, the first BTK inhibitor approved in CLL/SLL, dramatically improved outcomes for patients. But it's been associated with an increased risk of sudden death that are generally thought to be caused by cardiac irregularities and with ventricular arrhythmias, which are very dangerous irregular heartbeats, plus hypertension and other side effects. Acalabrutinib is a next generation, more selective BTK inhibitor that has been shown in head-to-head studies to be better tolerated than ibrutinib and equally effective. This study was designed to assess the risk of sudden death in these dangerous ventricular arrhythmias in CLL patients taking acalabrutinib compared to other therapies. What was the method and who were the participants? The data was aggregated from 5 different prospective clinical trials that compared acalabrutinib to different standards of care and to assess the relative risk of sudden death in ventricular arrhythmias in CLL patients. Standard of care therapies that were used as comparators were ibrutinib, bendamustine plus rituximab, that would be chemoimmunotherapy, chlorambucil plus obinutuzumab, also chemoimmunotherapy, and idelalisib plus rituximab. Idelalisib is another novel therapy, this time a PI3 kinase inhibitor. What were the results? The 5 pooled patients included 1,299 chronic lymphocytic small lymphocytic lymphoma patients who had received acalabrutinib for a cumulative exposure of over 4,568 patient years. There were also 585, which represented 941 patient years receiving one of the standard cares that was used in the comparator arm. If you just by raw extraction looked at the data from the 5 trials added up, they were found that there was 5 or 0.4 and 3 or 0.5 patients who had fatal ventricular arrhythmias and sudden deaths in the acalabrutinib and comparator arm respectively. However, after adjudication, and this meant by manual review, by looking deeply at the data rather than just extracting the raw data, only 2 of the 5 patients in the acalabrutinib arm and 2 of the 3 patients in the comparator arm were ultimately determined to have a fatal ventricular arrhythmia or cardiac-related sudden death. Looking at the risk per 100 years, fatal VAs and sudden death were fewer for acalabrutinib versus standard of care, but the difference was not statistically significant. These were small numbers. Non-fatal potential serious ventricular arrhythmias were reported in 2 patients in each group. Acalabrutinib, that meant 0.2%, and for the comparator arm, 0.3%. Again, although the acalabrutinib group had a longer exposure because they stay on the medicine continuously, while some of these comparator arms were limited duration. It had a lower exposure-adjusted event rate per 100 years of non-fatal VAs than the standard of care. The difference, again, was not statistically significant. You might ask, well, wasn't ibrutinib the problem in the comparator arm? But leaving ibrutinib out did not change the results. So what can we conclude from this? The risk of a fatal cardiac event was very low at approximately 1 per 1,000 patient years for acalabrutinib, compared to 3 per patient 1,000 years for the comparators. If only the adjudicated, in other words, if you only looked at the results after they'd been more deeply analyzed, the risk dropped to 0.44 per 1,000 patient years for acalabrutinib, compared to 2 per 1,000 patient years for the comparators. While none of these are statistically different, and any chance of sudden death is important to reduce to a minimum, the overall risk is exceedingly low. The results raise questions about whether increased cardiac issues are inherent with all BTK inhibitors, and all that we can do is lower risk, but it can never be fully eliminated. And although the median age was not stated in the abstract, complicating these speculations is we know that CLL patients tend to be elderly and therefore already at a higher risk for a fatal cardiac event. Perhaps long-term real-world data will offer better guidance in the future. Thanks very much for listening. Stay strong. We are all in this together.